Welcome to the workshop. We are focusing on suicide risk assessment and formulation in children and adolescents. This is a workshop for mental health clinicians, for mental health professionals who are working with young people and are concerned about conducting accurate and valid risk assessments about possible risk of suicidal ideation, suicidal behavior, and suicide in children and adolescents. When we conduct a risk assessment and formulation, we are interested in three primary components. The largest is risk factors. This is really overarching. All of the components can be considered risk factors, but this is having an understanding of the different risk factors, individual, family, community, that place a young person at elevated risk for suicidal behavior and suicide. Sometimes these risk factors, young people carry with them throughout their life. They have a chronic mental illness. They have a bipolar disorder. They suffered a trauma as a young child. They were severely sexually abused over a period of time. That's a history that will be a risk factor. We can't change that history. So with the risk factors, we're also looking at underlying static, they have them risk factors, as well as looking very carefully at their current suicidal thoughts, impulses, intent, and at their current mental status. And we put these three together to conduct a risk formulation. So the steps first, we have to manage our reaction to the youth and the youth suicide risk. This means being calm and collaborative, saying to the youth, we want to understand what is so upsetting, where the pain is coming from. We want to work with you to overcome that, to resolve it. And we need to manage our own anxiety sometimes in working with these youth so that we don't become too reactive and be unable to listen and let them tell their story. And we have to know what the risk factors are, the risk and protective factors, but particularly the risk factors. And we need to collect accurate assessment information about the risk factors, the current ideation and intent, the mental status, and then formulate a plan. When we talk about maintaining a collaborative, non-adversarial stance, this is something that we do whenever we're working with youth with any high-risk behaviors, emotional distress, youth who have difficult things to share. They're concerned about stigmatization. So we're trying, when we do this risk assessment, to create an atmosphere where the youth feels safe and they're able to share information. If we think about it, if they come in to see us or someone has brought them in to see us, either way, this is not something a young person does easily for most of them. It's not part of their usual behavioral repertoire to go talk with an adult about what's most troubling to them. Often, we've already crossed one hurdle just by the fact that they've come in for services. And what we have to make sure we do is not behave in such a way that they may never come in again or they may not come back. We want it to be a good experience, whether or not they stay in treatment now, so that they would consider coming in again at another time. So we want them to feel safe. We want them to feel able to share information. We want to let them know that we care and we want to help them and be empathic. Sharing an understanding of a suicidal state of mind, what is meant by that is to be able to validate or understand, given all the pain you're in, given the sadness that you're describing, all that's happening in your family. I can understand how you've come to this place today where you're having these thoughts. So what we don't want to do is say, are you crazy? You have such a good family. Okay? In other words, that would be very invalidating, even though we might think we're being helpful because we're trying to point out something positive. First, we have to really hear them and understand how they could have arrived where they are today. It's also important in beginning the assessment to discuss privacy and confidentiality. This is important in all of our work, certainly with teens, there's a lot of concerns about disclosure, about what will be shared, what won't be shared with parents, when will it be shared. I think often, we would begin an evaluation with the parent and the adolescent together. And I'm guessing many of you do this when we're working with teenagers. We tend not to see the parent first, alone, because the teenager is kind of like being iced in the waiting room. And it's challenging for them. They're wondering what the parent is saying about them. We tend to begin with the parent and teenager together. I want to say this is not an evidence base, so here I'm sharing something that's much more experiential to get us started. And that's where we would tell them the structure of the day. This evaluation will take about this long. This is what you can expect will happen during this evaluation. I want to be sure we talk about privacy. I'll be talking with you separately, and of course, if we have a concern about a youth's safety, then we're saying that it would be one of the reasons that we would share that so that we could get the needed help. And that concern about safety might be because they are reporting that they're suicidal, they're thinking about suicide. It might be that they end up reporting very severe substance abuse or alcohol abuse, and we're going to need to talk with the parent about getting services. It might be that they're reporting they're a victim of severe bullying, but there are different times in a vow we would like to have it out there that we will share it with others so that when we do that to get them the help they need, it isn't seen as a violation of trust. We've shared that up front. Okay, collecting accurate assessment information means eliciting information about the factors, about the ideation. It will also be inquiring about the availability of means and getting information from collateral sources, not only the parents, but if we're working with a youth who has previously been psychiatrically hospitalized, been seen by another mental health professional, we will clearly want to get those records. Sometimes we will go to the schools and ask parents to bring information back from the schools. So collateral information becomes quite important. We're only briefly in this workshop going to review the risk factors. We did cover those thoroughly in the overview on this topic that I hope you all have had a chance to review or are able to get access to. But the individual risk factors cover the gamut from the demographic risk factors such as girls being more likely to have suicidal thoughts and engage in suicidal behavior, but boys being more likely to die from suicide. The racial ethnic groups where we have Alaska Native and American Indian youth in America at the highest risk for suicide. So we have various socio-demographic risk factors. But more importantly, in the clinical setting, what we know is that a history of suicide attempt and a history of multiple attempts is our strongest risk factor for subsequent suicidal behavior and for suicide. We also look very closely at psychopathology, at mental health problems such as depressive and bipolar disorders, alcohol and substance abuse, and conduct problems, patterns of aggressive and aggressive impulsive behavior. Then we have a history of sexual abuse and physical abuse, psychological characteristics such as severe hopelessness, sexual orientation, and exposure to suicide as all being important risk factors. At the family level, we look at a family history of suicide, which is associated with some elevated risk, family psychiatric history, and family cohesion and support, which is a correlate of suicidal behavior. In the school, community, and social contextual level, we have some evidence to suggest that poor social integration, being isolated, being bullied, being the bully are problems in terms of risk for suicidal behavior. And then more available means in someone who is at elevated risk. At the point where they're at elevated risk and they're thinking seriously of suicide, We may not be able to prevent some of the other risk factors. They're already in play. At that point of prevention, what we can do is restrict availability of the means until we're able to help them with their problems. What you see here is a risk factor checklist for teen suicidal behavior in suicide. This has all of our main categories. What I think is useful for this, because it's on one page, these are evidence-based risk factors, that this is something that could be useful as a checklist when you're doing that first part of the risk assessment, which is being sure that you have covered through your interview, your assessment tools, your collateral interviews, any records you've received. Have you received the information that you need to know if these are present? So I think that this would be useful as a checklist. So it includes the demographic, the clinical features I've just described, the family interpersonal factors, and then recent life stress is on there. So a couple of things about the sheet. The ones that will end up being most useful clinically are the clinical features and the family and interpersonal features. The reason is that the demographic factors are not going to come into play in the same way when we're working with one young person in our office. Remember, even though boys are at higher risk for suicide, we do have many girls who die by suicide, and we need to take each of their expressions of suicidal thoughts, their suicidal behavior very seriously and evaluate them as well. So we're not going to minimize the potential suicidal risk of a girl. So the demographic are good background information. The recent life stress, the last one in here, is also good information. We almost always begin an interview, and one of the first things we learn is something about the function of that suicidal behavior. If the youth has made a suicide attempt, we generally want to find out what was going on. Some people call it a functional analysis or a behavioral analysis, where we try to take that target behavior they engaged in, suicidal behavior, and we try to understand the antecedents of it and the consequences of it. In other words, what was the chain? What went on? Is there a pattern to when a youth engages in this behavior if they have made multiple suicide attempts? By learning about the antecedents, we have some ideas if there might be something we could change in their environment and their life that might prevent it. By learning about the consequences, we learn something about the function of that, what the functions might have been. But the most common antecedent is recent life stress. And it tends to be loss, conflict, an interpersonal challenge, such as a loss of a girlfriend or a boyfriend. And this is not a point for prevention generally, because this is normative. It's quite common in young people's lives. It's common in all of our lives that we lose relationships. There are sometimes conflicts with other people. But it is still helpful to do this behavioral analysis so we understand the pattern for this particular youth. Because maybe what we'll learn is that there was sexual abuse, and that was a precipitant. Now that's interpersonal, but that's something where we need to very quickly intervene and take action. Maybe what we'll learn is that there is severe aggression in the home with a step-parent. We may be able to engage the family in some respite, some extra services. Maybe we need to get a parent into some substance abuse treatment. So it's very important to learn about the antecedents. Similarly, by learning about the consequences, we have an idea that perhaps with some of these youth, it is functional in that they're trying to change something in their lives interpersonally. So recent life stress is on here. It won't necessarily tell us a lot about their risk unless we learn about something such as abuse, where we can make a change. Okay, so that's the overview of the risk factors. Now, how do we go about eliciting suicidal ideation plans and behaviors? Well, first we make use of the attitudes that I discussed a few minutes ago. This is calm, collaborative, trying to create a safe environment. We need to be familiar with the suicide risk assessment tools that are available, understand their appropriate use, and we need to use strategies to decrease a young person's reluctance to talk about this distress and these thoughts. Being familiar with the tools, this is important because one of the most common requests that I get with emails and phone calls is what suicide assessment tool can I use in my clinic to determine a youth's level of risk? And there is not one. There simply is not one tool that will determine a youth's level of risk. And because, if you've heard about these risk factors, they are in all domains, individual, family, community, social context, and we don't have one tool that would cover all those in a validated way. Suicidal youth are highly heterogeneous. They vary on many dimensions. We have, from an extreme of an affectively labile, lots of problems with emotion, mood regulation, teenage girl who's abusing alcohol, has a history of sexual abuse. That might be one type of suicidal youth. But another type might be a 12-year-old, very withdrawn, severely depressed and anxious boy who might also be a suicidal youth. So I think sometimes when people are asking for the suicide assessment tool, they're thinking if you just ask about suicidal thoughts and behaviors, you'll know risk. But actually to do the risk assessment is to consider all of the factors that we've talked about. The tools, and we're going to talk about a few tools during the workshop, are supplemental, very useful, and we think of them as more information to consider. So some of the strategies are be direct and unhurried when interviewing. Be comfortable with the topic. If needed, use some desensitization on yourself or with your colleagues. Practicing asking about thoughts of suicide. I think what we don't want to do is when the teenager mentions that they made a suicide attempt a couple weeks ago or that they had to plan, we don't want the clinician to kind of fall out of their chair or just go into look shocked. Because that's actually, for many youth, exactly why they don't want to bring it up with an adult. They don't want to deal with the adult's emotional reaction. They often aren't sharing things with their parents because they don't want to deal with their parents' emotional reaction. So we want to contain that for them. And sometimes with very challenging and sensitive topics with teenagers, we actually bring them up first in an interview, and you may have used this technique, where we even say near the beginning, and it would be okay to talk about this and this and this. Because once the words have been said, it's actually much easier for any of us to join the conversation. And remember that no, when we ask a question about have they had thoughts of suicide, if a youth says something like no, not really, we don't just go on. I do find that what has happened in some settings is because they're trying to take a more systematic approach to risk assessment, we have seen development of risk checklists, which are perhaps not so different from the one we looked at here. But the difficulty is if we have clinicians who are hurried and they feel a time press, which can easily happen if the hint of suicide risk comes up late in an interview or comes up when the hand is on the doorknob and the young person is going out of the room. But once we go there, we have to be careful we're not just check, and they see us doing that, and they're thinking, well, you're pressed for time, I don't really want to be here. I'm learning, think learning principles very quickly that the less I say, the shorter this will be. What we want is whenever you go there, even if someone is left waiting, that we try to take this approach. Because with youth who are at higher risk, we don't know if we'll get a second chance, if they will share this again when they come in. So no, not really. We always ask in our interviews about suicide risk in at least a few different ways, and we give them some time to respond. Okay, a little bit about interviewing strategies before we get to the instruments that we have a bit more data on for lowering this threshold to talk about it. And these you may use in other areas of your practice too. Sean Shea has written quite extensively about these. Normalization is to put it in the context that this is not so unusual, and there are many other youth who have had these thoughts. So it would be saying something like, sometimes what I found is when a teen feels so badly, they have thoughts of suicide or killing themselves. I wonder if you've had these thoughts recently or ever. A gentle assumption is you just ask how frequently, right? This is how we evaluate for alcohol and substance abuse. We don't say, have you ever had a drink of alcohol? I mean, that would actually be almost silly in the United States. And it's not to say there's some youth who have not, but it's fine for them to say, no, I've never had it. We always ask how much and how often. And it's going to be similar here. This is that idea. How frequently do you have thoughts? If you're with someone who you have reason to believe. Another one that is actually shame attenuation, which is very similar to normalization, and that is something that, given all that's been happening in your life with the move and the loss of your father, and how you're saying you feel each day, I wonder if you've had thoughts. So again, as the person doing the interview, you're not suggesting that you would be shocked by this, that it would be shameful. You're suggesting that it would be, I could understand this. Symptom amplification, all that's referring to, it's very difficult not only to find out about suicidal intent with young people, but to learn what they actually did after they make an attempt. Many of them give a very rough estimate or a lowball estimate, particularly with these ingestions. They often do feel ashamed or they're embarrassed after the fact. And we kind of take some of that away by just saying, how many pills did you take? Was it about 30, 50, 100? So they're not debating, should I say it was 5 or 12? They can always say it was a lower amount. And then we ask very specific questions and do a lot of very behavioral interviewing if there has been a suicide attempt. Some of the clinically useful instruments, one is the Suicidal Ideation Questionnaire Junior. This is 15 items and relatively easy reading level, very strong psychometric properties, both in terms of its internal consistency. It has some predictive validity, a lot of concurrent validity. And this is what this looks like. It's asking about thoughts that people sometimes have, and we're asking the young person to say which of these they have had in the past month, and then they're filling out on a 7-point scale that is scored from 0 to 6, how frequently they have had these thoughts in the past month. So for instance, let me read a few of these questions. I thought it would be better if I was not alive. I thought about killing myself. I thought about how I would kill myself. I thought about when I would kill myself. I thought about people dying. So it includes morbid ideation. I thought about what to write in a suicide note. I thought about telling people I plan to kill myself. I thought about how people would feel if I killed myself. So you can see there's an interpersonal piece to it as well. I wished I were dead. I thought that killing myself would solve my problems. I thought that no one cared if I lived or died. And the response options are almost every day to I never had this thought. So one thing you can see This is available. I mean, this is one of these, a publication company has this. I believe it's Psychological Assessment Resources. An advantage of using a scale like this is that it would be perhaps challenging, not impossible, but this is a lot of questions about death and dying to ask in a row in an interview. Whereas what I find, I have used this with literally hundreds of suicidal teens, they have never minded filling this out. Simply have never minded. They tend to fill it out completely. Remember, if you were having these thoughts, you might actually experience relief that someone finally asked you. And they can do it quite rapidly. This is something you can give a young person on a clipboard while they're waiting. I would put it with something else, so you're not just evaluating this. Or you can complete it during your evaluation, have them do it, and then talk with them about their responses. It is scored. They have validated a clinical cut point, which is a score above 31. But often in the clinic, we're not scoring it right at that time. What we're doing, what I find, is we're scanning the responses. Now, if you are at a clinic or an agency where you may not be able to purchase these, you can also think about drafting some of your own questions, even a small number, and having the youth respond if you might want to do that, and have a chance for some youth to respond in writing as well as in the face-to-face interview. Okay, a second one is the Beck Hopelessness Scale. And in adults, this has even had some predictive validity with suicide. But if you're looking at in young people, this is a self-report scale, true, false, 20 items. This one I would not use with children, elementary age. This one was with adolescents and adults. It was developed for adults, but we now have a lot of psychometric data to show that it is a good tool to use with adolescents as well. With children, this has not been used. It's very cognitively oriented in the reading level and some of the concepts. Again, there's some evidence of predictive validity. Now, when we say evidence of predictive validity, what I mean is it is statistically significant and clinically significant to the extent that it's one more bit of information that can help inform us in terms of the overall risk formulation. But it would not in and of itself be sufficient information for a risk formulation. Because what it doesn't tell us, so the predictive validity, it's a significant predictor. What we're talking about here is those with severe hopelessness are more likely to make a suicide attempt over some extended period of time. What we're often trying to do in a risk formulation in our clinical setting is know more about what is the risk now so we know how to intervene clinically. Is this something we're just going to watch and continue to assess while we treat this child with evidence-based treatments for their presenting problems? Or is this something that is so acute that it now becomes the first target of treatment, right? So that's what we're trying to differentiate here with suicidal youth. Most of them will have other problems that you will be targeting in your treatments. If you're working in some community agencies, you're targeting the sexual abuse, the problems of the family. You're working in mental health clinics, you're trying to target their severity of depression. You're trying to get treatment for their bipolar disorder. You're trying to help them with the substance abuse problem. And what we want with suicidal youth is that you use these evidence-based treatments for whatever the presenting problems of the youth are, while you consider the potential suicide risk and intervene appropriately. So some of this is in the hierarchy of what we're treating now, given that I think in general, across our field, regardless of discipline, we put safety first. And you're probably putting the treatment of all these other problems just below safety. So one of the questions we're addressing here is, right now, do I need to specifically address suicide risk because it's acute? Or have I recognized that there is an elevation of suicide risk? I'm going to continue to evaluate that over time and watch it while I treat some of these problems like depression, like alcohol dependence, that are creating the risk. So it's what's my target now? Or perhaps you'll find out there really is no elevated risk. This is the Beck Hopelessness Scale. So again, as you can see, it's one page, it's true, false, and this can be completed in a relatively short period of time. Okay, a third useful instrument that is definitely newer is the Columbia Suicide Severity Rating Scale. This has been primarily an interview format. The group who developed it have been disseminating this internationally. It's now in several languages. It is, they are developing a self-report. They are developing brief versions. I think it's a strong instrument. It can be used in some ways as a dimensional instrument where you get a score. But really what it is geared for is to do an interview about a history of suicidal ideation and behavior, and to differentiate very specifically if there have been plans and preparation. I mean, this instrument will ask, not only is there a history of a suicide attempt, but is there a history of an interrupted attempt where it may have actually happened had someone not come in the room. Okay, there are youth who begin to hang themselves and someone comes in the room. An aborted attempt where the youth themselves decided not to continue. It also assesses yes, no for a history of deliberate self-harm. If the youth does report suicidal ideation, there are a number of questions about that ideation, the duration, how long it lasts, the controllability of it. And some of the work that we are doing is actually looking at what aspects of ideation are most predictive of an attempt, and we hope that will be out soon. This can be used to assess for both past week, which is the way this is being implemented in emergency settings. It can also be a lifetime. And this is just to give you a sense of what it looks like. It's 2 pages or more. It's 2 pages of very dense text or more. And what you'll see, this is available, and we can make this available to you on the website. But what you'll see is the first questions are about ideation, and this is how many you have about suicidal thoughts. This whole part on the bottom of the first page is if there are suicidal thoughts, what's the frequency, duration, controllability, were there deterrents? And then the whole second page is about suicidal behavior and physical injury. And this is being used now in the United States with FDA-sponsored trials. It is an effort to more clearly classify. There have been issues with the classification of self-harmful behavior that has made it hard to know what we're working with. So this is really an effort to have very clear definitions and classification of what happened. An offshoot of this is what was used in the FDA-sponsored analysis to look at adverse events and suicide attempts possibly associated with the use of antidepressants. And that was a similar classification system was used with blind raters rating the adverse events that had happened in those pediatric antidepressant trials. And you may be familiar, that's the time when the FDA, I believe in 2004, put a warning on just because there was a hint of a pattern looking like there may be an association. Okay, so we have looked at the risk factors, such as on the checklist that we went over. We have conducted a calm, a sensitive interview trying to lower the threshold so the teen would talk about their suicidal thoughts, and perhaps supplemented that with these self-report instruments, which is a way of collecting sensitive information from people without bombarding them with quite as many questions. And some people, as you know, respond more in writing easily, and some respond more verbally. And I think whenever we're trying to assess something that's difficult to learn about, offering more options, we're perhaps more likely to reach more of the youth. So the warning signs from mental status, we want to know clearly if they're threatening, what they're saying, what they're talking about, but we also want to get from this mental status and exam a sense of how agitated are they, how hopeless are they, are they struggling with thinking logically, coherently. As you probably know, psychotic disorders and schizophrenia are not very common in children and adolescents. We tend to have a late adolescence, young adulthood onset. So we're not talking about that because it's not one of the most common factors associated with youth suicide. However, there are some youth who are psychotic. So if you have someone who is hearing voices telling them to kill themselves, this is something that would come out in a mental status exam. But more often, what we're getting is the agitation, the hopelessness, and the message that I don't see an out. I don't see any way to solve my problems. If you're in a lot of personal, emotional pain, and you don't have a good capacity for problem solving to see options, you really have a young person who says, I either continue to live in this pain, or I could die, because they've got a tunnel vision going. So one of the things we're doing in a mental status exam with an adolescent is trying to get a sense of their capacity for problem solving, their ability to see options. And there is some work that has been done, and this is not surprising, that at least correlates problem solving with a lower frequency of ideation. Okay, so that's where we are with we've covered these three categories. Now, how are we going to put them together with a risk formulation to figure out level of risk?